Hey folks, Rob Haddo here, and I would like to talk about pain scales today. I'm having a really high pain day myself, and I figure that's just one of those perfect times to talk about pain. And for those of you who don't know, or for those who might not use it in your practice, a pain scale is one of any number of different ways of allowing a patient to rate their pain or of trying to create a rating for pain. We're often taught to use them in charting as a diagnostic criteria or a criteria for progression through recovery from, say, an injury or chronic pain condition or what have you. And I've noted that in pain circles, in pain science forums, things like that, people have kind of been shitting all over them. They've kind of said, oh, they don't have any really place in rehab anymore. They're antiquated, and in some ways, yeah, they're an antiquated tool. They're old school, and they're not that great for diagnostic purposes. Agreed, they're useless for that. But for empowering our patients, they're fantastic. Remember, we're not treating people; we're treating persons. We're not treating crowds and masses. We're treating an individual. That individual in front of us has their subjective experience of pain. And the subjectivity of that pain scale makes it perfect for that. So, for those of you who don't know, I'm a massage therapist. And where I'm trained, where I work, we have a pretty big scope of practice. It includes all manners of remedial exercise, stretching, resistance, acceleration, deceleration training, sport-specific rehab, all of it. And so it behooves us to be able to empower our patients further to say, okay, yeah, you're in clinic to help feel better. You're in clinic for the calm shit down phase. But outside of clinic, or even during clinic, we can take you through remedial exercises for the build shit up phase of your rehab. Those pain scales are fantastic. The one I like is the Numeric rating scale, the 0 to 10 point scale. It's broken up kind of in three main segments. So it's 0 to 10, and 0 is nada. 0 is no pain. 10 is all pain. And so 0 to 3 is kind of our safe range. With my patients, when they're doing their exercises, that's where I like to keep them, actually. Because trying to take someone who's been in pain all their life and get them pain-free, that's quite often unrealistic. Keeping them safe, however, keeping them informed as to what's an acceptable level of pain for them, that's much more manageable, and that pain scale comes in really handy there. It's a great part of patient education. So I can say, okay, Sally. I don't treat as Sally, but now apparently I do. Sally, when you're doing your remedial exercises, keep it in the 0 to 3 range. And 0 to 3 is the point at which you can easily ignore it. If I'm talking to you, if I'm giving you instruction, or if we're talking about the weather, I don't know, it can go into the background without much conscious effort on your part. It's there, but it's really not very insistent. 4 to 6 is where it starts to become insistent. 4 to 6 is where the pain you're experiencing can start to interfere with your daily living. That can can start to affect your daily living, can start to affect your capacity for work. And trying to train or rehab through that, you might be pushing yourself too far. That gets to the call me and we're going to troubleshoot this. And then from 7 up, we're at extreme pain. 7 up is a soft drink. From 7 up, we have 7. 7 is where it hurts so bad you're almost vocalizing. 8 is where it hurts so much you have to vocalize. 9, you're vocalizing loudly. And 10, in my mind, is the point at which you are about to lose consciousness. You're about to involuntarily lose consciousness because of the pain you're experiencing. And so if we walk our patients through that simple scale, okay, if it's like a 0 to 3 for you, you're generally good to go. Versus 7 to 10, you're coming in here, and 4 to 6, give me a call. We've given our patient another very simple but very effective tool in their roster. And the subjectivity is what's so useful for this. Think about it. People like myself, this pain scale is based on tolerance, but it also includes awareness. For someone like me who's always in pain, I have a relatively high capacity for pain tolerance, because I have to, that's normalized for me. But I have a very low, or also very high, I should say, sensitivity to pain. It takes very little for me to hurt. I'm already hurting the vast majority of time. I turn a door handle wrong and I dislocate my thumb. That sucks. But I can also be like, oh, well, oops, and kind of clunk it back and fiddle with it, and I'm good to go. And so it took very little to make my pain a lot more loud, but I can also tolerate that pain being more loud, which means that my functional scale, my 0 to 3, what it takes to get me there, to actually push my tolerance, might take a lot more. What it takes to keep me there takes a lot less. And so I can use that same numerical rating scale for myself to determine how safe am I in working out. How safe am I comfortable with this? I just downshifted a bit. And so for myself, I tend to count it as like a 0 to 2, maybe 0 to 3. If I start getting at 4, I know I'm not training or moving. I know I'm not going to push myself. Fine for walking, fine for doing groceries, not for doing acceleration deceleration training, not for doing lateral cutting drills or any sort of crossover drills through my legs, because that's where I'm going to fail and roll an ankle and hate myself for the next 6 to 8 weeks. For someone who's, a pain typical, someone who doesn't experience daily pain, someone who's quote unquote normal, they might have a 0 day to day. It might take a decent amount of stimulus to get them to perceive pain. They don't have those, oops, I stepped wrong, or turned a door handle wrong, or whatever it might be. But when they do experience pain, it's louder for them. Their brain is more sensitive to that because it's more novel for them. And so again, that same scale now becomes a bit more normalized for them. I can say, okay, in that mid-range, when you're experiencing something like this, we have imaging that shows there's no injury to that knee. We can work through that a little bit. And then we have contextual data. And if we say over the course of several workouts that drops, we're on the right track, even if it started at a 5 out of 10. Whereas someone who's, again, more input sensitive to create output pain, like myself, that 5 might represent a point where it's going to ramp up for me, or that 4 might keep ramping up. That 3 might even keep ramping up. And so now all of my patients have access to this understanding of what works for them pain scale-wise. So yeah, is a numeric rating scale useful for diagnostic criteria? Hell no. Everyone's so different. We're all complex meat bags. It's not that great. Is it useful for each complex meat bag? Hell yes. Do I think that we need to poo-poo it and kind of cut it out of pain science? No, I think that's shit. I think we should keep using it. I think as we move towards a more patient-centric model, as a lot of people already have done, that it becomes more viable. Or whatever scale you like, the visual analog scale or the Schmidt index, that's the insect stings, whatever. You know what I mean. Whatever scale you like is good. I feel like I'm rambling now. I feel like I'm just repeating myself, or at least I'm going to start repeating myself, which means it's time to kibosh this video. So, thanks for listening. Have a great day.